Kamarudin, will be on COVID-19 infection prevention control update. And secondly, our Assistant Professor Dr. Afira binti Zainal Abid regarding COVID-19 management updates. And let's not forget Assistant Professor Dr. Muhammad Abdul Shakur bin Abu Hassan, our Head of EDCC, regarding COVID-19 SOP updates. So as we know, on the 1st of April, we are transitioning into the endemic phase. So this is where we actually waiting. Everyone keep asking, is there any changes in our SOP or in our daily new norms? All right, without further ado, I would like to invite our first speaker, Assistant Professor Dr. Nur Hidayah binti Kamarudin, to give away our speech.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you, Mr. Chairperson. Okay, allow me to share my screen first. Okay, everyone can view the slide clearly?
Yes, Doctor.
Okay, so Alhamdulillah, first and foremost, thank you everyone for being able to make it to today's updates on COVID-19, infection prevention and control, management and SOP. So Alhamdulillah. All right, without further ado, my part, basically, I will talk about updates regarding the infection prevention and control specifically for COVID-19. Okay, majority of my slides are based on the latest guidelines and policy updated by the KKM at the end of this February 2022. Okay. All right. So as far as the COVID-19 transmission is concerned, nothing much changed. The prior knowledge that we have that COVID-19 can be transmitted, is transmitted via respiratory droplets. That is the main mode of transmission. And then we also know that by having a close contact with an index case or person that is infected, okay, upon touching a contaminated surface, you can also get COVID-19. And on top of that, it is also known that COVID-19 virus are able to sustain a limited airborne transmission. Okay, that's remained the same. Penyebaran COVID-19, which is melalui close contact, titisan pernafasan dan juga melalui udara. Alright, so the three modes of transmission. Alright, so for us in a healthcare setting, we are basically not in the position to avoid COVID-19. They will come to us, regardless the patient or us staff ourselves. We are at risk. And listed here are the factors affecting the risk of acquisition when we are in the healthcare setting. The first one, among the important things that menyebabkan risiko jangkitan itu berlaku, the first one is due to the poor ventilation within the facility. There are certain areas within any institution or any healthcare facility, there are areas where ventilation is poor. For example, dalam pantry yang bertutup ataupun dalam surau yang bertutup. Ada aircon, tingkap tutup. That is example of a setup which is of poor ventilation. And this condition akan menyebabkan peningkatan risiko untuk mendapat COVID-19 infection. Alright. So another factors is that the proximity, healthcare worker proximity to the index case. Index case ni regardless they are the patient, most of the time they are unknown of COVID-19 status, and on top of that, index case can also be among the staff. Healthcare worker proximity. Alright. The other one is the duration of exposure. Most of the time, those who acquire COVID-19 from index cases are usually exposed quite a long amount of time to the index case. That's why they are getting infected by COVID-19. And on top of that, the usage of PPE also one of the important factor, inappropriate use or inadequate use of PPE. Tak pakai mask. That one itu one of the common findings. Inconsistent wearing of mask. That is another one. Right. Hopefully those who are not speaking, please mute your mic. And on top of that, the index case behavior also plays an important factor. For example, index case ni, for example, a patient unable to wear mask, or he or she is frequently coughing. That one we cannot control, but we have options whether to protect ourselves or not, by wearing mask and proper PPE and so on. And days of illness also plays an important role. If you encounter the index case earlier on, the risk of transmission is much more higher as compared to the encounter that occur towards the end of the infective process. All right, in an endemic kind of setting, transmission via fomite or contact with contaminated inanimate object can be an important mode of transmission. But however, if the load of the infection within that particular setting is not that high, basically the risk of transmission via a fomite is basically lower as compared to the usual mode of transmission. Okay, and the most important things that I need all of you to extract from my presentation is basically the risk of getting COVID-19 is severely reduced if you are doing all the followings. Frequent hand hygiene, try to get as much opportunity as you can to perform a hand hygiene, regardless if you have alcohol swab with you. Perform hand rub. If you don't have it, find a sink. Basically, our facility is very much equipped with all the facilities, all the sinks, all the kemudahan tu adalah dan mudahlah untuk kita perform hand hygiene. Please don't use the excuse of you being busy doing your work and you don't perform a frequent and proper hand hygiene. Please don't, because part of your work is to protect yourself from the risk that your work is giving you, which is perform hand hygiene, and then perform an effective cleaning and disinfection of high touch surfaces. This one, regardless whether it is in a clinical setting or outside of clinical setting, effective, frequent, regular cleaning and disinfection of high touch surfaces is very important. What are the example of high touch surfaces? For example, inside the ward, you have your nurse's counter, you have your telephone, you have your computer keyboards. So clean it regularly using the disinfection solution provided, or you can use alcohol wipes, disinfection wipes, and it is there to make your life easier. And on top of that, wear mask, and if you need to use other PPE, wear it as per SOP has stated. And try to increase the ventilation of your work area as good as possible. I have made a few recommendations to site supervisor or clinical ward supervisor, sisters, and so on, to look into the ventilation inside the ward, in which if it is possible to open the window from both sides of the wall, open both sides, and if one side only can open, you may need a mechanical assist in ventilation, for example using fan and so on. Okay, and the positioning of the fan is also important, and not to be put in an incorrect position. This one, for further guide, I think you can refer to Infection Prevention and Control Unit for further advice for ventilation. All right. As far as the IBC strategies is concerned, we still focusing on the early rapid recognition and source control. All right, because we cannot stop the case from coming to us. What the best that we can do is basically to control the source, which is one of the most important things to promote is that respiratory hygiene, because we know the main mode of transmission of COVID-19 adalah melalui respiratory droplets. So we encourage untuk our staff, untuk public, amalkan etika batuk dan bersin yang betul. This one I also encourage every department at the gate, at the front door, for you to put some visual cues or signage that educates all the members of your department on, and which includes the public, right, to amalkan etika batuk dan bersin yang betul, because this is very important. Wear mask if you have symptoms and so on. And on top of the first strategy, we at the Infection Prevention and Control Unit also promotes the adherence of our members, our hospital members, to the standard precautions. Standard precautions and universal precautions are the same thing, and it should be applied to all patients, regardless of the patient status, especially among patients that is of unknown status. Right. So these are the list of standard precautions that is being promoted over and over again all across our presentation, okay, infection control presentation. So the first one is to maintain a good hand hygiene, use of appropriate and correct use of PPE, okay, respiratory hygiene and cough ethic, cleaning, disinfection and sterilization, safe injection practice and proper handling of needles and sharps. So standard precaution is standard, all right? Okay, on top of the standard precaution, you have this transmission-based precaution. Since we know how COVID-19 is being transmitted, so in attending suspected or confirmed cases of COVID-19, we encourage our staff to apply this transmission-based precaution, namely whether it is of contact, droplets, or airborne precaution. For COVID-19, we implement the higher most precautions, which is of the airborne precautions. Right. So I think by now you should all be familiar what are the components of this transmission-based precautions. Okay, you have contact precaution. Contact precaution mainly involves wearing layers of protectives around your body, which is the glove, which is the long sleeve gown, and on top of that, a proper hand hygiene. What is common among all these transmission-based precaution is that you cannot omit your hand hygiene part. Hand hygiene is very important for each and every transmission-based precaution. For droplets precaution, it is more focused on the transmission of respiratory droplets, so it emphasizes on the usage of mask and face shield. For airborne precaution, because the droplets is very tiny and minute, wearing a usual mask, a usual surgical mask cannot protect the wearer, so it requires a special mask, which is, I think all of you familiar, the N95, and other higher level respirator. And on top of that, the settings should also be suitable in terms of ventilation and air circulation and so on. All right. So other than applying standard precaution, transmission-based precaution, we have other methods, other strategies for us to implement this IPC, which includes administrative controls. Administrative controls that we have over here, we are talking, for example, our SOPs. These are the administrative controls. On top of that, environmental engineering control are also in need to support our activity. And on top of that, the new thing that is being introduced by KKM, and we adopt these strategies, which is the surveillance program. For information of the audience, for the healthcare associated COVID-19 cases, they are being monitored. We are gathering data and we share it with KKM Putrajaya to look into the extent of the magnitude of infection that occur within the healthcare setting, especially in our hospital, SASMEC. And the last strategy is that is being included, which is the vaccination of healthcare worker. So we talk about this afterwards. Towards the end of my presentation, I will highlight a little bit more on vaccination. So these are basically the steps that have been in place for us to control the source of the exposure to COVID-19 in our healthcare facility. All right. So I need all the members of the SASMEC, our healthcare worker, to work in together. All right. Among the things that we have already in place, we limit the number of entrants. Number of entrants that we limit for the time being is basically the visitors and the caretakers. We are not that concerned of our healthcare worker because you are all aware when to turn up yourself to the Sejahtera Clinic or to emergency department for further testing if you are in suspicion of you getting COVID-19. But for the public, we don't have that sort of control. So we should still limit the number of entrants to our healthcare facility. And certain places do use physical barrier to reduce exposure. Okay, physical barrier that I'm talking about here can be in the form of plastic barrier at the counter, for example, at pharmacy counter, at the clinics counter. Some of the clinics do use this physical barrier. All right. And we still screen patient, caretakers, and visitors, and even we screen our staff if you all have suspicion that you have symptoms and so on. All right. So we have resources to perform hand hygiene. Hand scrubs are all over the place. So I hope every members of the hospital use these guna kemudahan yang disediakan and always maintain a physical distancing of more than 1 meter. This one, we all should be alert and aware among, especially distancing among your colleagues while doing your work. Sometimes you can be indulged. Okay, aku syok sangat buat kerja tak perasan duduk berkumpul ramai-ramai dengan kawan-kawan sekerja, which is most of the time it is tidak mematuhi SOP lah. So seboleh-bolehnya atau you must jaga this physical distancing at least of more than 1 meter kalau boleh. If tidak boleh dielakkan, you have to work closely with your colleagues, try to limit the time, okay, not to be tidak expose dalam situasi begitu untuk jangka masa yang lama. Okay, that's another way of you to control the source. Right. Other than physical distancing, kita masih lagi mengamalkan universal masking. Maksud universal masking is that the staff is wearing mask, the staff, the patient, the visitor, and the caretaker. They all should wear mask and adhere to it as close as possible. And with regards to the latest guideline released by KKM, the guideline highlight the use of well-fitted face mask. Pakai face mask yang rapat di muka. you can have certain lubang-lubang di tepi-tepi mask, tapi kalau lubang yang kecil tu it is acceptable, tapi make sure it is fit perfectly and it require less of you to adjust your mask. When you require less attempt to adjust your mask, means that the mask fit you well. Okay, and other than universal masking, wearing of other PPE based on current SOP, and on top of that, cleaning and disinfection of high touch surfaces. Again, this one needs to be highlighted. Okay, cleaning and disinfection of high touch surfaces ni, it is ideally the one that is in charge of that workspace yang buat cleaning and disinfection ni. Okay, untuk patient punya area, we have our housekeeping staff from paramedic or advanced pack. Tapi di area bekerja kita sendiri, kita kena regularly clean and disinfect our workspace, because it is you who are working there. Alright, so penggunaan PPE should be optimized, and the usage should be rational and appropriate. Kita kena balance between our protection versus wastage of resources. Kita kena guna secara berhemah dan guna secara berpatutan. Okay, among the things that still in place, I think this one still we implement all of these things in order to optimize the use of our PPE. For example, the first one, kita ada COVID-19 ward, which involve cohorting of confirmed COVID-19 cases. Bila we cohort all of the patient within the same room, the designated healthcare worker that have to look after this cohort of patient akan dioptimize jugalah in terms of number, so that pembaziran PPE itu tidak berlaku. Dan this one more to management basically. For example, the management of patient that is reduced to a safe care level. Maksudnya try to limit the direct close contact among healthcare worker towards the patient to a very minimum safe care level. Okay, this one I think Dr. Afira will highlight or will know more about this one. And focus about planned activities if you are involved in managing COVID-19 patient or managing COVID-19 suspected patient. Alright, and consider use specific PPE only if in direct close contact, not when it is inappropriate. For example, you just want to see the patient from far. No need lah for you to wear a level 3 PPE, for example, like that. Alright. And all of these precautions should not compromise the quality of care and jeopardize patient safety. Dia tidak sepatutnya menghalang kita daripada deliver perkhidmatan kesihatan yang berkualiti kepada pesakit, dan dia tidak sepatutnya membahayakan keselamatan pesakit. Alright. So, the effectiveness of PPE among healthcare workers. Alright, we have had multiple sessions already berkaitan dengan training of PPE, penggunaan PPE. So training is an important part to ensure the effectiveness of PPE usage dekat setting kita. And on top of that, we have supervision. Supervision yang dilakukan daripada site supervisor dan juga daripada infection control team. But however, regardless of how many training that we give, how close supervision and monitoring we do, it all depends on the compliance of our healthcare worker. Okay, so compliance is very important. I think by now you should already very much well versed with this thing. It is not something that we impose it to you, but you have to impose it on yourself, because it is your safety, and on top of that, the safety of your colleagues and the safety of your patient. Okay, even though you are vaccinated, you are still having the risk of getting infection with COVID-19, and you can serve as the agent of transmission of COVID-19 to your colleagues and to your patient and to your family members. So healthcare worker compliance to PPE is very, very much important. Okay, face mask is the one of the most important PPE material for prevention of COVID-19. All right, most of you, I think, wear surgical mask, but nowadays, from my observation, I can see that quite a number of staff also started to wear KN95. There are all types of KN95 brands that are available in market, which is of very much comfortable for you to wear. Most of KN95 is 4 layer, 4-ply, as in contrast to surgical mask, which is 3-ply. Okay, so of course, the 4-ply will give a better protection as compared to the 3-ply surgical mask. Okay. All right. So the minimum is the surgical mask. So for cloth mask, staff are not encouraged to wear. This one for public lah. In healthcare setting, we have to stick to surgical mask and beyond. All right. Okay. Physical distancing coupled with face masking and wearing a face shield or eye protection will give a good protection against COVID-19. I'm sure by now you are all know. I think this image also viral in Facebook. The risk is significantly dropped if the index case and you both are masked. Okay, 1.5% risk of transmission if both are masked. All right. Mask is also one of the important parameters that is being assessed when we are in DCC, for example, performing an exposure risk assessment. Okay, if you wear mask or face shield, your risk might drop to low. Okay, and if the source is well controlled or not, by means of patient is masked or not, or in this case is masked or not, that can further drop the risk to medium and also low. So if both are masked, definitely the risk of you getting the COVID-19 is definitely low. Okay, so make sure you wear your mask at all times. And on top of that, other than wearing masks, of course, the risk assessment will be done according to the rest of the parameters. I think you are all familiar lah. Exposure lama mana, okay? Exposure tu berlaku dekat mana, ada gejala ataupun tak, and so on. Alright, I think for the recommended PPE in SASMEC and IUM, it is still status quo. Pre-endemic, endemic phase type of PPE to be applied in SASMEC and IUM is still the same. So here, it is more likely of a revision rather than updates lah for the PPE part. Okay. So the one that we are using is basically the minimum standard that is being set in accordance to the KKM guideline also. Right, so semua kena pakai mask, okay, in public area, admins area, the guards, okay, pakai mask, frequent hand hygiene. Alright, so this one I've highlighted previously that the mask should be fixed tightly to your face, because when it is fixed, it can further prevent or limit the spread of COVID-19. Alright. Right. So it should be wear in a manner that it fit most to your face. It should protect your nose. It should protect your mouth and down until your chin. There can be slight gaps, no problem, but it should fit just nice to the areas of your face that is supposed to protect. All right, in clinical area, this is our standard level 1 PPE, where it is still applied. Not much changes on this one. Okay, surgical face mask, facial apron, and gloves. All right. Okay, for the reception counter that is equipped with physical barrier, wearing a surgical or a face mask is already adequate. All right. However, in the absence of physical barrier, uh, distancing should be ensured more than 1 meter, and transmission can further be reduced by you wearing face shield. Okay. Frequent hand hygiene, not to forget. All right. For example, another example, a counter in emergency department, at triage counter, for example. In this setting, you have your physical barrier, so it should not be an issue. But on a complete set of PPE should be made available, because in case of emergency, you can straight away don a complete PPE to attend emergency cases. In a cold, non-emergency area with a physical barrier, I think wearing a surgical face mask is already adequate. All right, this one in the examination room or consultation room, for example, in emergency department. Okay, this one level 2 PPE, droplets precaution. Okay, examination room and consultation room also the same. If you are attending a case suspected of respiratory infection, the minimum is for you to wear a level 2 PPE, which is of droplets precaution, is already enough. For ambulance driver, the same. If you are the ones that is driving the ambulance, not the one that is handling handle the patient at the back area of the ambulance. So the ones that is at the back, who are supposed to accompany the patient should wear a level 3 PPE airborne precaution. Right? Okay. For any aerosol generating procedure that is being performed on PUI or confirmed COVID-19 patient, a complete level 3 airborne PPE, sorry, level 2 airborne with N95 mask. Okay, the minimum recommendation. All right, for the staff at the specimen collection area, okay, complete PPE with N95 mask, long sleeve gown. So this is basically the same. Any queries on PPE? I think we can have a Q&A session afterwards. Okay. PPE to provide care for PUI or confirmed cases. Still status quo, okay. In managing a PUI or confirmed, this is the ideal setup, the ideal PPE that, but we don't have this one quite enough for us to maintain its usage. But if these options of PPE setup is not available, you can always resort to options 2, wearing a coverall with N95, okay, or option 3, okay, long sleeve full gown with N95 face shields and so on. All right. Although while attending patients that is not known to have a COVID-19, it is always good to wear N95 mask if you are subjected to perform aerosol generating procedure onto the patient. Right, attire of the cleaner. Okay, this one, if the cleaner is subjected to clean the COVID-19 ward, for example, or rooms. All right. So the universal PPE selection for cases of PUI or attending SARI patient in SASMEC and IIUM still wearing an N95 mask, wear an isolation gown which is of fluid repellent and long sleeve, and on top of that wear plastic apron, gloves, eye protection, boots and shoe cover, and head cover. All right. So we try to minimize the variation of PPE as the best as we could, okay? Because variation might create confusion, and confusion is not safe for our healthcare worker. All right. This is the PPE material that is required for staff to send sample to the lab. Okay, face mask, apron, gloves is enough. Okay, this one for labs. For labs is also status quo. If you're handling a COVID-19 specimen, should wear a 95 and complete set of PPE. For other general purpose of processing specimen, which is of not COVID-19 specimen, we can wear the droplets level 2 PPE. Okay, performing AGP, same. Okay, attending patient with influenza-like illness and performing aerosol generating procedure, of course, N95 and the rest of the complete PPE. All right, so I would like to encourage the members of the audience, if you happens to encounter any occurrence that may contribute to the hazard to the health of other staff or the health of other patient, you can always report. This one, for example, healthcare personnel did not wear proper PPE while attending patient, or on the right side of the slide, if you encounter sharps in the domestic waste bin, please report. So any compliance alert with regards to IPC, you can always snap picture, state the location of the incident, you can name the staff that are involved, together with date and time. You can WhatsApp to OSH SASMEC, okay, at this number. You can also save this number 010-539-2650. Reporting is very important because it needs to be investigated and managed. Okay. Kejadian tersebut tidak wajar untuk dibiarkan berlalu begitu saja, because dia mendatangkan risiko kesihatan kepada staf dan risiko kesihatan kepada pesakit. So please, okay, right? WhatsApp, if you encounter any of this compliance alert. Alright. The latest KKM guideline also outline how frequent that you want to clean your workspace. Alright. The minimum is at least twice daily. For example, at screening counter, at least twice daily. You can do it before you start your work and before you end your shift. At the end of the day, at least twice daily. In patient's room, okay, also twice daily. This one basically areas that are of not managing a PUI or a COVID-19 patient. Okay, the minimum is, for example, twice daily, and you should pay extra focus on the high-touch surfaces. This one, clean it regularly, twice daily or 3 times daily, up to the personnel that is being in charge at that area. Okay. For hallways and corridors, again, focus on the high-touch surfaces. For example, the railings, equipments in the hallway. Okay, at least twice daily. Okay. And when being in the common places, us as a healthcare worker also should mind where our hands are placed. Kita sentiasa aware tangan kita ni ada dekat mana. Always keep it to yourself and try to minimize touching the area that is unnecessary for you to touch. That is a very good habit lah. Try to keep your hands to yourself. Okay. All right. Okay. Right. Okay, last but not least, the booster shots. So I'm quite confident that almost more than 50% of our hospital members are already received booster shot for COVID-19. However, there are still a significant number of staff that are still not being boosted. All right. So what is known so far? Apa yang dah diketahui up until now, protection against infection and severe disease yang diberikan oleh primary vaccine, your first and your second dose of COVID-19 vaccine akan berkurangan over time. Okay, this one is already being proven. There are lots of publication and you can all refer to that. Okay, so primary vaccination punya effect akan berkurangan, confirm. And on top of that, what make it worse, the COVID-19 virus itself changes over time. Meaning akan ada new variant yang emerge, and this new variant most of the time akan datang sekali dengan package of increase in transmission. And on top of that, the latest Omicron yang kita ada ni further have this feature which can evade any prior immunity that is being produced by the vaccination or even previous natural infection by COVID-19. So the virus are evolving. So this very much emphasizes that we need to be vaccinated, we need to be boosted, and we should have a good prevention effort. These are all the components that is very important untuk mengelakkan transmission, especially in a healthcare setting, also di setting di luar hospital. Alright, and booster shot itself is proven to increase the immune response among participants in clinical trial. And when the immune response is increased, of course, the protection against COVID-19 infection akan improve. And on top of that, akan further improve development of severe disease. Okay, so for those who have not yet been boosted and berminat untuk mendapatkan booster, you can go to this website. vaccinecovid.protecthealth.com.my/find. Okay, just fill up the information and the website akan give out the list of healthcare facility yang masih offer booster di kawasan yang berkenaan. Alright, so on top of that, team of SASMEC is also on the way untuk dapatkan data of our healthcare worker, how many of us have received booster, because we need to monitor on that. As far as the COVID-19 task force SASMEC is concerned, booster is not yet being made compulsory, selaras dengan kenyataan yang dibuat oleh YBKJ. Not compulsory, but it is very much encouraged and recommended for you to get this booster because it will boost your immune response. Okay, so I think this is my last slide. Last for my slide, but you haven't had the two presenter. Okay, Fadi, back to you.
Thank you, Dr. Nur Hidayah. Okay. So I think there's no question yet. I think we can proceed to the next presenter, which is I welcome Dr. Afira to give her talk regarding COVID-19 management update. Please welcome.
Okay, can you all see my slide? Boleh? Okay, Assalamualaikum warahmatullahi wabarakatuh. So today I'll be talking about COVID-19 management updates. There are lots of updates when we are embracing the endemic. Okay, so again, we are entering the months of Ramadan. So let's remind each others about the verses of Quran. I'm reminding myself again. So the ayat of waman ahyaha faka'annama ahyana sajami'ah kan. So siapa yang menyelamatkan satu nyawa seperti dia menyelamatkan seluruh manusia kan. Dan we must remind ourselves about the previous verse, man qatala nafsan biwairi nafsin aw fasadin fil ard faka'annama qatalan nasa jami'ah. So siapa yang bunuh seorang, dia sama juga seperti membunuh seluruh manusia kan. Banyak echo okay. Lepas tu so why I'm mentioning this ayat is actually because we don't want double standard care for COVID-19 patient. Okay, so beside, I want to remind everyone, SASMEC is actually tertiary hospital. We are not super, we are not quarantine center. So please treat our patient properly. Kalau dia perlu imaging, please do the imaging. Please have the attitude that you want to help the patient, not you are trying to find a way to reject the request. Okay. So again, it's actually the hadith about kita ziarah orang sakit kan. It's actually Allah kata dia dah siapkan satu tempat kat syurga, and there is actually 140,000 malaikat kan. So kita tak perlu nak tunggu Lailatul Qadar, malam Lailatul Qadar. We are in this profession together. So let's remind each others to do the utmost best for our patient kan. Sebab real this 1 month we have incident of upper GI bleed patient, sampailah patient to bleed hypoperfusion, because delay is actually because the patient COVID status. And then we have a patient with liver function test up until 600, but the ultrasound was not granted because COVID status. So again and again, I'm seeing all these things. So again, a reminder to everyone, we must do the utmost best for our patient. Lepas tu lagi satu, we are going to enter endemic. So lots of patients will come to us. It's actually incidental findings. They comes with other complaints, but the RTKs turn out to be positive. So that's why we need actually to really do without double standard lah. Lepas tu, kalau you all ada concern, is actually about contracting the virus. Actually, when you wear proper PPE and you do the procedure for the patient, the risk is actually very low. And basically, most of us, ataupun di hospital ni, outbreak ataupun the cluster, the recent cluster is actually mostly because of you got it from community, not from the hospital per se. Okay, so if you wear proper PPE, the risk is actually low. So I will talk about actually from my slide is actually from ID physician all over the country lah. So the next things is actually the introduction. I believe at this phase you know the virus is actually SARS-CoV-2. So it's belong to Coronaviridae family. Okay. The things about SARS-CoV-2 is actually it is actually potent inflammatory cytokines inducer. So it is more transmissible, and when the patient they have a risk of causing a pulmonary phase, the pneumonic phase then. And then this is actually the total case from the beginning of the pandemic. So now we are entering the 5th wave, the Omicron wave, and Alhamdulillah we managed to go through. And this week is actually really significant reductions of the numbers of patients being admitted even in our hospital. So about the variant is actually you know about Omicron. Okay, so bila kita cerita pasal variant ni is actually macam dia beranak pinak lah. Okay, so dia mutate tu is actually the mutation causes is actually because dia ada host. Maksudnya ada human host. Maksudnya selagi ada manusia, selagi ada host, selagi ada middle people ni, dia akan continuously mutate. And you know it's actually BA2 is actually highly transmissible. So you can see it's actually the case rising before this. And then one of the things is actually we don't know what's going to happen in the future. So what is actually the variant that we are going to see. So for example, even BA2 ni is actually monoclonal antibody pun likely not effective. So that's why we need actually macam Dr. Hidayah sebut tadi, you need to wear proper PPE, hand hygiene, cough ethics tu kena betul sebab you nak putuskan is actually rantaian COVID-19 ni. So this is our own ward, so we can see the peak in February, then slowly coming downtrend. So again, this is a revision. So we can see that COVID-19, you have the viral response phase and then post-inflammatory response phase. So basically category 1 and 2 early infection, category 3 is when they have pneumonia, and then 4 and 5 is actually when they require oxygen supplementation. Okay. So this is all the categories. So stage 1 is asymptomatic, stage 2 symptomatic, no pneumonia. And again, stage 3 is actually pneumonia but no hypoxia, stage 4A, 4B, 5A and 5B. And even it's actually the recent one they categorize because they dah introduce home quarantine policy ni. So they educate public about 2A and 2B. So 2A is actually when you develop mild symptoms and 2B is actually when you have lethargic, the more severe symptoms. So dulu kita macam admit everyone lah, high risk je, category 2, pregnant, semua kita admit kan. But now it's actually because the peak, now we have criteria for hospital admission, not everyone lah basically. So pregnant mother in category 2, moderate and above, all category 3 and 5 disease, unstable condition, uncontrolled comorbidities, all this is the one that we admit. Okay, and then dulu kita memang tunggu patient sampai end of quarantine period dia, but now no more. Once stable, we allow you to go back to your home and isolate at home. Okay, so dulu kalau macam we said about immunocompromised patients, semua kita macam kena repeat RTK at day 20 and then prolong isolation. But now we said beyond 20 days we can actually end the isolation. So later probably everyone should be able to manage category 1 to 3, okay? So you need to re-stratify, identify the warning sign and early detection of hypoxia. So who is actually prone to high risk disease, can develop the severe disease? So you know it's like age, comorbidities, obesity and HIV if they have a low viral load. Okay, so when they develop severe disease, usually at day 5 when they entering pulmonary phase, and this is how you predict, okay, rising CRP, symptoms wise and all the features of radiological imaging. And then this is warning signs of COVID-19 when they have a new persistent or new onset fever, lethargic, anorexia or cough, and then when they desaturate, okay, CRP high, lymphocyte count low, and then the neutrophil lymphocyte ratio more than 3.13, and there is evidence of worsening chest X-ray finding. So usually it happens at this phase in between viral response phase and post-inflammatory response. So the warning sign is actually at day 5 to 6, okay? Sometimes in Omicron we can see it earlier actually. So what you need to do during your rounds, okay, so this is actually common for COVID and post, but basically you need to anticipate that in future everyone should be probably will manage their own COVID in their own isolation room. So you need to look for warning signs from the symptoms, whether lethargic, diarrhea, and then clinical examination, desaturation, okay, tachypneic, and one of the common things is actually silent tachypneic. So you need to calculate manually your respiratory rate. And then lab test, you can see abnormal lymphocyte count is less than 1, single CRP more than 5, high neutrophil lymphocyte ratio, and radiological finding as well. So early detection of hypoxia, this is one what we call, you can always do at ED, Cat 1, Cat 2, Cat 3. So you just need to do sit to stand test. So you bagi dia pasang oksigen SpO2, lepas tu you suruh dia duduk duduk bangun for 1 minute and tengok if whether there is any desaturation. Okay. Lepas tu, this is also the monitoring, repeating slide. Okay, so again, this is reminder that most of the patient, 80% is actually between category 1 and 2. But you have only 20% actually hospitalized for category 3, 4 and 5. Okay, so please, again, we need to manage them properly. So this is actually previous guideline how you manage Cat 1, Cat 2, Cat 3 ni usually supportive sahaja. And basically in our guideline, Malaysia guideline, they mentioned alternative we can give this medication but not available yet. Okay, stage 4, when they require nasoprong oxygen, you can start DEXA. And then if they progress to stage 4B, worsening SpO2, so then you increase the DEXA dose, okay, daripada 6 tu jadi 24, okay, and then you can also increase whether DEXA or methylpred to mg per kilo OD. And then if they worsen to hypernasal cannula, then you can add on tocilizumab, toci 1 dose, okay. When they go into stage 5, this is actually the drug methylpred or toci, ataupun you bagi steroid and baricitinib. So this is actually the summary. Okay, so you start with 6 to 8 if the patient is stable. Sometimes dia daripada step up, but sometimes dia daripada step down lah, maksudnya datang dah very bad tu, so you start daripada ni, then you step down slowly. Okay, so what is actually different? The guideline going to update soon is actually the role of antiviral lah. So for example, in this case, 67-year-old male completed 3 doses of COVID-19 vaccine, hypertension, diabetes, dyslipidemia and CKD, had close contact with daughter. So dia datang tu memang fever and cough, lethargic. So this is actually warning signs. And then oxygen okay, even post-sitting, standing test okay. No desaturation, but you can see the CRP, the hyperinflammatory marker is high. So this is actually category 2B. So category 2B lepas ni they all akan manage as outpatient dengan dekat CRC. So this is actually the drug yang KJ sebut, Paxlovid. Okay, so this actually they use actually during the viral phase. Okay, so this actually antiviral. So they use the Paxlovid basically at this stage lah. So during the viral replication phase. Okay. And then timing of intervention is essential lah. So basically you nak guna antiviral ni at the early phase. Okay. Lepas tu now it's actually they are also remdesivir lah, the next choice. Okay. So in general, patient with COVID-19 illness should receive symptomatic treatment, antipyretic, nutritional support, maintenance of fluid and electrolytes. And then we can see that young, healthy, asymptomatic individuals during Omicron ni less likely to progress to severe disease, especially those vaccinated, okay, boosted. Antiviral ni, kalau Paxlovid ni masuk Malaysia pun, basically kita akan bagi pada high risk group symptomatic patients and particularly which warning sign. So this is actually the comorbidities that increase someone to have a risk of severe illness, and this is the warning sign. You can always see this in guideline. So this is actually NIH guidelines, so they also advocate Paxlovid ni. But in Malaysia juga sebenarnya macam Hospital Mizan, diorang ada Sotrovimab ni, and then remdesivir pun we are still waiting lah actually. So again, this is actually the preference based on the evidence is actually Paxlovid, and then baru lain-lain. Okay. So what is good about it is actually dia memang ada 88% relative risk reduction for the primary endpoint. So related COVID-19 hospitalization or death from any cause. Fawiprawi dulu kita guna, so but now lots of evidence kata no extra benefit in prevention of desaturation, ICU admission and mortality. But then there is also study yang kata fawiprawi ni reduce viral load and improve clinical radiological outcomes and safe and well tolerated in treating COVID-19 patients. Okay, this is another case shared by ID physician. So common presentation. So we have 60-year-old male, non-smoker, DM, hypertension, obesity, presented with fever and sore throat for 3 days. So dia datang breathless, open walking, no other warning signs. So basically dia buat sitting standing pun tak ada desaturation, CRP very high and you can see the chest x-ray bilateral ground glass opacity. So in this kind of case, we can start remdesivir. So once kita ada stock, we can start lah actually. So again, remdesivir ni we can use in mild to moderate disease and then guideline kata sebelum ni 4A, 4B, 5A. We rarely use, actually kita combine dengan DEXA tapi kita tak guna dengan toci atau bari. There is no what we call as triple therapy lah. And then upcoming guideline, insyaAllah dia akan mention about we can use in Cat 2B and Cat 3. So early remdesivir dia akan prevent progression to severe COVID-19 lah. Again, they result in 80% lower risk reduction, okay, rather than placebo. So one of the good things about remdesivir is actually you know like macam the current emerging variants macam tadi kita kata BA2 tu semua dia ada limitation dekat monoclonal antibody therapy, but this is actually promising drug that actually have good effects towards the emerging new variants. Okay. So case 3, for example, this patient came DM, hypertension, complaining dyspnea, RTK antigen positive. So you can see oxygen is low and then put on nasoprom 97%, CRP 20 and chest x-ray ada minimal ground glass opacity. So naturally dulu is actually kalau kita tengok case ni tadi CRP dia 20 lah, okay. High juga, tapi what we learn is actually sometimes we can watch and see lah actually. So not all patient yang kita perlu start actually steroid. So tapi kalau macam patient yang high CRP, high inflammation phase, then we start. Because we can see actually during Omicron, contohnya macam lots of patient masuk sebab heart failure actually. CRP cuma 3 sahaja. So this kind of case no need actually to start lah. Okay. Sebab basically steroid may cause a deleterious effect. So lots of maksudnya they can get bacterial and fungal super infection. Okay. And then kalau patient tu misalnya case yang seterusnya ni CRP dia low kan. And you can see very big the heart is actually cardiomegaly, very big heart, and then you know that basically desaturated pun because of decompensated heart failure, CRP low, then probably you don't need to start actually DEXA. This is actually the latest one, okay. Kalau dulu semua patient kita macam decide je, kita must start steroid. But nowadays it's actually the guidelines going to change lah, okay. So what we can do, we can observe closely, sama macam dengue kan. So you need to watch out whether there is any desaturation, review the patient frequently, and then if they desaturated, CRP increasing, then you know they are going to inflammatory phase, then you can start steroid. Okay, again you can see actually in Omicron ni tak macam Delta. Delta memang prolong kita manage patient. Kadang steroid tu lama. Tapi dalam Omicron ni 1-2 hari kadang we can actually wean down, maksudnya reduce the DEXA dose. Okay. And then this is actually the approach, the new approach. Kalau dulu kita semua requiring oxygen je kita dah start steroid. Tapi now there is actually alternative cause detected, macam contoh decompensated CCF. high white cell count, high procalcitonin, so you suspect bacterial, you suspect maksudnya acute, maksudnya fluid overload sebab acute renal failure. So all this kalau dia tak ada hyperinflammation, basically kita tak start steroid. But if you have evidence of hyperinflammation, so what we call evidence of hyperinflammation, high neutrophil lymphocyte ratio, elevated or rising CRP, elevated or rising ferritin and elevated interleukin 6 kalau you ada, so then only you start with steroids and immunomodulators. So this guideline is going to come soon, okay? So once the Paxlovid, everything is going to Malaysia, once we have the stock, so basically this is going to happen lah. Okay. So lesson to learn is actually among vaccinated patient, kita tengok less clinical deterioration. This is true enough So most of the times managing Omicron phase ni kita akan tengok turnover patient tu cepat, okay? And then patient with hypoxia, you need to consider lots of things. Are you dealing with PE? Are you dealing with pneumonia? Are you dealing with heart failure? Before you think about COVID-19 which inflammatory phase, okay? And then in patient with risk factor to deteriorate, etiologies tu may overlap. Sometimes sebab cytokine release syndrome, sebab viral effects of the disease, and decomposition of underlying comorbid illness, PE, nosocomial pneumonia, all these can overlap, okay? So again, the key message is actually no one is always correct and forever good at COVID management. We are all still learning, okay? Even the guideline is actually forever changing. So this is not something we learned during our undergrad, but now we need to continuous learning about this. Please get good history, correct examination, vigilant monitoring to determine COVID category, phase and complication. And then do consider antiviral for high-risk individuals, Cat 2 or 3, okay, subject to availability lah. So bila kita nak dapat Paxlovid, bila kita nak dapat remdesivir ni, I'm not sure. So once we got it, we can always consider it, okay. So and then dulu kita rasa macam semua oxygen requirement kita cakap steroid initiation. But now it's actually not oxygen requirement not equivalent to steroid initiation unless in hyperinflammatory phase. Okay, high dose steroid may carry deleterious effect. So if you want to give tu, you kena fikir betul-betul lah. Memang indicated then you give, okay. And then CRP or imaging alone is not sole indication for escalation. Sometimes de-escalation juga. Sebab sometimes imaging ni dia lambat kan. So patient clinically they're improving. So clinical condition and progress play main part of the assessment. So my last words is actually please no double standards. We are all learning. Please treat your patient properly. Okay, that's all. Thank you.
Thank you very much, Dr. Omo Afira. I think we can proceed with the next presentation by Dr. Muhammad Abdul Shakur bin Abu Hassan. He will present regarding COVID-19 SOP update, the latest one. So please welcome, Dr.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Dengar ya.
Dengan
Okay, Assalamualaikum warahmatullahi wabarakatuh. So thank you Dr. Shakir for the introduction. So I hope everyone's still okay to go on with the next presentation. Okay, so as you all know, the 1st April there will be a few changes in the SOP. We are going to the endemic era. So hopefully this update today will ease and smoothen some of our process throughout this period. Okay, so before that, I just like to show all of you again as a reminder that we have our COVID guideline from the last year in the website of SASMEC. Okay, if you go to the SASMEC at .iim.edu.my, you can just go scroll to the bottom, and you can see this guideline. And then when you click on the guideline, you will see the COVID guideline here. Okay. So whenever you want to check for the guideline, you can look in this guideline first, and then because this was last year, so there are a few changes. If you're query about the changes, you can contact EDCC. All right. Okay. So for the updates, there's only a few updates we changed. Okay. So most of the SOP that we have in the COVID guidelines, still we can use it. Someone is not. Okay. Sekejap ada orang tak mute. So okay, maybe Syakir boleh tolong tengok kalau ada yang tak mute tu. Alright. So sekejap. Okay, so only a few changes we're going to have. So one of it is pre-admission and also pre-procedure. Okay, so before this, as you all know, before this, all new patient will require RTK swab. Okay, either from clinic, okay, from daycare, from ED, from PAC, all admission need RTK swab. Okay, but currently because of there's a lot more people doing self-test COVID test at home, we will accept the self-test result if the patient is positive. Okay, so for patient who came to the hospital with a positive COVID test, all right, and they already register themselves in the MySejahtera, so we are no longer require RTK swab. Okay, as long as they are still in the positive period lah, in the quarantine period too. Okay, so previously we have questions, okay, especially in the gatekeepers lah, the PAC, the ED, or the clinic sejahtera. Okay, so if patient already positive with saliva test, do we still need to do RTK swab? Okay, so for starting 1st April, if they are already positive self-test, we are going to treat them as positive. Okay, so we are not going to take swab again, so they can just use this positive result as the result for positive, and then they are going to be, if they require admission, they're going to be admitted into the COVID ward. Right. Otherwise, all other patients, we still do RTK swab, except for patients who are post-COVID, so which is the next one. Okay, so for post-COVID patient who already infected with COVID, okay, so do they still need RTK swab for admission? So the answer now is that they don't need the swab for 90 days. Okay, within the 90 days of the first result they are positive. Okay, kata the first result of positive is 1st April, so for 90 days from the first result of positive, they don't need to do swab unless they are having a new COVID-19 symptoms. Okay, new COVID-19 symptoms. For example, after maybe 1 month, they start to have new symptom again, cough or fever or diarrhea, right, related to COVID-19 symptoms. So you can find these COVID-19 symptoms in the many guidelines out there. You can also go through the COVID-19 MOH punya website, and you can have the list of symptoms over there, right? So if the clinician thinks the patient is having a new COVID-19 guideline, then they can do swab, RTK swab to confirm. So if the swab is done and it turned out to be positive, we are going to treat as COVID-19 reinfection and to be admitted to COVID ward. Because previously, as Dr. Hidayah and also Dr. Fira already some sort of mentioned it, previously we know that after about 90 days, they will not get reinfection. But now with the Omicron, there are people who got reinfection even though within the 90 days period. Okay, so so for post-COVID, for now, we're going to we don't have to do swab for admission. Okay, if the patient still within the 90 days and no new symptoms. Okay, so if there is a new symptom, you need to do swab. Okay. All right, and then another changes from the guideline is that the pathway. Okay, so previously we have PCW, which we call probable COVID ward. Okay, but now already changed to pediatric COVID ward. Okay, so the pediatric COVID ward, as you all know, is at the level 2, just above the PAC. So we can for the pathway, previously all COVID patients need to go to down at the lower ground via ambulance, COVID ambulance, and then they're going to use the COVID lift to go to the COVID ward. Okay. However, we because from ED and from PAC, it is we use more resources to go down and then use the lift number 5, which is just behind the PAC and also beside the ED. Okay, so for that we change the pathway from PAC and ED can go straight to the lift number 5, COVID lift number 5, which is at the ground floor. And we are going to communicate with security to just hold the traffic at the corridor while we transfer the patient. Okay, so because that area is a common area, sometimes people go to Surau. Okay, and then also students coming through and there, and also patient and staff. So we're going to ask staff from ED and staff from PAC, if you want to admit patient to PICS COVID ward, we can now use the lift number 5 from the ground floor. No need to use COVID ambulance to go to the lower ground. You can straight away from your department to the lift number 5 using the ground floor corridor. Okay. And then for the decon team, I think we have a team from paramedic here. So for decon team, okay, prior to transfer, patient and staff need to make sure they all are wearing PPE. So patient, of course, need to wear their mask. Staff handling COVID need to wear level 2 PPE with N95, the minimum, or you can use level 3 with PAPR, okay, the most optimum. Prior to transfer, and if already adequate PPE, we don't need to decon the pathway, okay, because the risk is minimum of transfer. Okay, so before this, we have the decon team will be standby, and then they're going to follow the patient, they're going to spray the floor, and then someone will mop. So we don't need to do that anymore, and we just going to do the regular cleaning at the pathway. All right. And then the lift, because of the cases, the number of cases is a lot nowadays, like last month. And then we expect maybe during the Ramadan, the bazaar will be open, the Salat Tarawih will be no more distant anymore. So we expect the number will still increase. So instead of the lift to be regular decon per patient, we're going to do a regular decon of the lift COVID number 5 and number 9 3 times a day. Okay. Okay. So, and then the next one is the written from long leave, or a new staff coming to report duty, or even a new postgrad student coming to report for duty. Okay, from the previous SOP, we require all of these staff who are having long leave or coming to report duty to do PCR a day before they start working. Okay. But for the new one, starting 1st April, we are going to ask all the asymptomatic staff to do RTK saliva self-test, okay, and monitor, and this process monitored by supervisor. If it is negative, they can allow straight to work. If they are positive, they are going to treat as positive, ask them to report to MySejahtera and undergoes their quarantine, or go to the CAC for assessment if required. Okay. If the staff coming back from leave or reporting duty is symptomatic, then they need to go to do their PCR as per the symptomatic healthcare worker. So they need to do PCR. They can go to the clinic sejahtera, okay, and then they just follow the symptomatic healthcare worker flow, okay. And then supervisor can also inform EDCC to arrange for swab. For example, if they are supposed to come for work tomorrow, for example, but they are symptomatic today, they say they have cough and runny nose, fever, they inform their supervisor. Supervisor can arrange their swab dates with EDCC. Okay. Okay, this is SOP for gathering or exam. Actually, there's no change for this. It's just that if there's a lot of gathering, the external people is advised to do self-test before the gathering. They must do self-test before. Otherwise, if it's internal from SASMEC itself, they don't need to do test. But this one, doesn't change much. Okay. All right. I think Dr. Hidayah might already touch on this, but I just going to remind again, because this is going to relate with the next updates. So I want to remind all staff who already vaccinated. Okay, you need to check your status, especially someone who are taking Sinovac. Okay, as you can see here, if someone who taking Sinovac, if they have 2 doses, they are considered partially vaccinated. Okay, if they are in between the 18 and 59 years old, so they need to take another dose. Okay, okay, so they need to complete 3 doses. Okay, so as Dr. Hidayah already mentioned, they have a website where you can look for the vaccination center all over all the country. So you can go, if you are having Sinovac 2 doses, then maybe you should look for it, because starting from 1st April, you are going to be considered partially vaccinated. Same with someone who take CanSino, Janssen, and Sputnik Light vaccination. If they are first dose and above 60 years, I think most of us is less than 60 years. So if above 60 years, they need to repeat a booster, right? Otherwise, most of us is taking Pfizer. So 2 doses is still considered as fully vaccinated starting from 1st April. However, we advise you to, we encourage and we advise you all to take the booster. Okay, we might not sure when it will change. Okay, all right. And then because of this, here is the changes, the updates that we are going to do. Okay, so whoever staff or new staff who is unvaccinated or partially vaccinated, as per previous SOP, we actually require them to do weekly professional RTK swab okay, at the swab booth to allow them to practice in SASMEC. And then, of course, they need to use the strict PPE adherence as per infection control guideline. And if they are not comply to the weekly RTK swab, they are not going to be allowed to enter SASMEC. And this should be monitored by the supervisors. Okay. And then the action can be taken if they are not comply. All right. So that's why we want all of you, we advise to take for booster, okay? Because we're not sure if the vaccination status might change as the 60 years old for Pfizer. Okay, most of us are Pfizer, so we're afraid that this might change to 18 and 59 years also. All right. Okay, we also noticed that some of the staff are not complying with the SOP, with the PPE attire. Okay, and that's why we have a path to report, which is we can report and we can take pictures and report to the OSH, as per Dr. Hidayah already mentioned earlier. But we also going to enforce some action to multiple offender. Okay, if we noted that staff who are not complying with the PPE level when treating patient multiple times, okay, if supervisor noted this, they can inform their HOD, and then the HOD can request the data from us.
Dah ada dah feedback form. Isi dah ke?
Oh, feedback form apa tu tak? So, okay. So supervisor can inform their HOD, and if indicated, the HOD can request the data from us, and we can show them how many times the staff or the offender not comply to the PPE level, because we all have documentation on whether they're wearing appropriate PPE or not. Okay, when handling patient. Okay, and then they can investigate further and either advise the offender or ask for explanation letter or any other action they think is appropriate to them. Okay. Okay, here I think Dr. Afira already mentioned, okay, primary team roles for COVID patient, because as endemic approach, we see a lot of Cat 1, Cat 2 in our hospital. Also in emergency department, we see that patient came for other causes, but noted to be positive. So they are either asymptomatic of COVID, or they only have minimal symptoms of COVID, like sore throat or runny nose. Okay, but they are coming for a different reason. So the primary team should manage them appropriately, as mentioned as per Dr. Afira just now. So COVID ward, you can consider COVID ward as a multidisciplinary ward, and all of you can go in. I've been to the COVID ward. Okay, so they are very good in making sure the staff entering the ward is wearing the most appropriate PPE. So I think COVID ward is actually the safest area lah untuk kita from getting infection. And most of us is actually getting the infection outside, okay, outside, or through with our colleagues, for example, and the community, right? So actually, when treating patient, when we wear appropriate PPE, should be no issue. So should be no issue for us to treat our patient appropriately. Okay. Okay, we also have a new flowchart for visitor for death in line cases. Okay, death in line meaning that only patients who are DIL issues and they are already at the brink of their death lah. Okay, so for this flowchart, okay, as you all can see here, if the patient issued DIL and the specialist or consultant in charge allow for family member to visit, So if they are not allowed, so cannot lah. Maybe for some sort of reason, they are not allowed the family member to visit. So if they are allowed, you can the team from the ward can ask the staff nurse in charge to fill up a form, online form. Okay, and from this online form, you will see the staff nurse in charge will put on the list of name whoever can visit. Okay, after they fill in the form, they need to inform the ADCC team. So ADCC team will inform the screening counter, all right, to allow the staff, the family member to enter SASMEC. If not, if the specialist allow the family member to enter, but EDCC and screening counter were not informed, there will be a miscommunication there, and the family member will not be able to enter SASMEC. Okay, will not be able to enter SASMEC, and selalunya dia akan ada macam perbalahan sikit kat bawah tu. Okay, because we were not informed. All right, and then we will not show what are the cases. So so that's why we do this flowchart. So staff nurse ward need to inform EDCC, and then EDCC will inform the screening counter, and then all the visitors need to do a saliva test. Okay, and if positive, of course, we will not allow the visitor to enter. If negative, we can allow the enter. But there are criteria for visitors. Okay, the patient must be a non-PUI patient and not COVID-19 case. All right. Meanwhile, the visitor also not a PUI or COVID-19 or under quarantine. All right. So let's say if they come with in a family, for example, adik-beradik come, one of them is positive, should be the other colleague should make sure they are not close contact and they are not symptomatic lah, before they can enter. So visitor must complete vaccine, asymptomatic, and age more than 80 years old and above, and only 2 relatives allowed at one time. Okay, and the duration should be not more than 30 minutes. Okay, and of course, ward nurse make sure they are wearing a mask and follow the SOP strictly. Only one time per person to enter. So 30 minutes should be long enough for them to say goodbye or for them to bacakan Yasin. So should be enough. All right. And then only close family members are allowed, which is a spouse, husband or wife, and then biological children, biological parents. And then if the patient is someone who unmarried, no children, so they may allow siblings to visit. Okay. If the criteria not fulfilled or too many visitors, we advise them to do virtual meeting or video call only. So maybe only two enter the enter the ward and visit the family member, and then they do virtual meeting. Right. So again, saliva test, we all know, is at the level 2 screen counter, right? During office hours. If after office hour, after 9 p.m., staff nurse from ward to monitor the saliva test at the PAC area before enter. Okay. So going back to the slide, lastly is that recently our Ministry of Health, KJ, mentioned that petugas KKM positif COVID kembali bekerja di hari ke-6. So for this, we are still quarantined for 7 days. We are not following this yet at the moment. Okay. So alhamdulillah. So our hospital want our staff who infected with COVID to have a proper rest and come back when they are really well. Okay. So from me, that's all. So if there is question, you can ask away. Okay, if no question, I return back to Dr. Shakir.
So I think if I can see in the chat box, okay, there's one question, Dr. Shako. Yang ni kita dah jawab. If air condition wards, how do you advise regarding ventilation? If we open the windows, condensation will occur, risk of fungal growth, etc. And then is labor considered AGP like intubation, hence need for identifying infusion gown. Dr. Shako maybe can.
Usually kalau kita ada COVID case, kita tak advise actually air condition lah. So memang kena buka, open the windows. So tak buka lah, maksudnya open the windows, kita tak buka lah aircon sekali sebenarnya. So that is the response for first question. Yang second question tu is labor considered AGP like intubation. So basically patient in labor ni kalau dia positif, the issue is not about the labor tapi about the, faham tak, bukanlah LICOA tu ke isunya, tapi adalah respiratory issue, your surrounding area ventilation lah. And mostly in labor patient, dia orang kata apa, actually tak akan pakai mask, in pain, so likely untuk transmission tu memang tinggi lah sebenarnya. That's why healthcare worker need to be protected lah, pakai N95, face shield, gown.
Thank you, Dr. Afira. There's one more questions from Iliana Hassim. From long leave, how many days they need to do a saliva test?
For long leave tu, just before they return, they can do the saliva test. Okay, if they are asymptomatic. If asymptomatic, let's say tomorrow they're coming back to work. So today they can do saliva test and then they forward to the supervisor, cakap is negative. So then you can come to work. Okay, just untuk masuk kerja saja. Bukan bila masuk kerja tu kena pantau lagi, tak perlu. Just untuk masuk kerja, make sure you are negative. If you are positive, again, if the saliva test turn out positive, then you are positive lah, tak boleh masuk kerja. Dan kena follow the quarantine 7 hari, kalau fully vaccinated, quarantine 7 hari, right? So if symptomatic, then you just inform straight away to the supervisor, you are symptomatic. Okay, and then you can go to Klinik Sejahtera ataupun supervisor can arrange swab with ADCC. Right?
Okay, I think if there are any last burning questions, kalau ada siapa nak tanya lagi. So I think kalau tak ada, we can end the session. So I would like to thank Dr. Hidayah, Dr. Umar and also Dr. Shako for the excellent presentation and sharing. So I hope all benefits and updated regarding the latest SOPs and everything. So I think we can end this session with Tasbih Farah and Surah Wal-Mas.